So again, for those of you that don't know me, I'm Angela Hogan, and I am one of the allergists here at CHKD in Children's Specialty Group and at Eastern Virginia Medical School. And tonight we're going to talk about food allergies in the school and kind of what you need to do as a parent and also as an educator or a school nurse that may keep your children safe and ready for that environment. I do want to update a couple of things that have happened in the last 2 weeks that I think are very exciting. First of all, I was able to do an in-service for 105 school nurses from Hampton and York County and Newport News this week, or last week. And then today I actually was able to do the in-service for Chesapeake Public Schools and also Portsmouth Public Schools. They had about 82 school nurses. So I think this is very encouraging because they want to know how to be prepared. They had more questions that I could answer in an hour and a half. And I was back in the back of both times, probably for 30 more minutes answering questions. They're very motivated and concerned about keeping our children safe in the public school systems in our area. And we're very lucky to have a coalition of nurses that actually have come together and put together a life-threatening allergy management plan for Hampton Roads. And there are not a lot of places around the country where 8 different public school systems have come together to provide this resource for education for the nurses, and then as it trickles on down to the other individuals. So I think that's exciting, and it should be reassuring to the parents who have children in those public schools that your school nurse is in fact prepared, educated, and ready to accept your children in the public school setting. And certainly we have many partnerships with private schools, one for example Norfolk Collegiate, which is with us tonight, who are always very proactive in terms of making sure that they're prepared for allergic children in their settings too. So I welcome you all, and now we will talk a little bit about food allergies. So this question has come up 10 times probably, and in fact it was the lead-off question that I had this morning from the first school nurse that raised her hand. This is a story that just made the news, obviously, at the end of July, and I've had so many very concerned parents because the way that it was initially portrayed in the news is that this 13-year-old whose father was a physician got 3 doses of epinephrine and accidental peanut exposure, and subsequent to that she passed away. And everyone that has, my patients have asking me and saying, well, does that mean epinephrine doesn't work? Does that mean epinephrine doesn't work? I have tried very hard to read all the articles that I could find on the internet, and I will say I don't know this family and I didn't talk to them directly, but I do know a little bit about food allergy, and certainly in my 23 years experience, what I seem to read between the lines here, and I am taking a little bit of liberty, I will admit, is that there probably was delayed administration of the epinephrine. She inadvertently had what she thought was a safe Rice Krispie treat that had peanut butter frosting on it. They were outside, it was dark. She did spit it out, but the next mention in most of the articles is that at about the 20-minute mark, she had extreme respiratory distress, and that's when they started administering the epinephrine. So I wonder, and I'll never know unless I meet this family, whether or not there were signs that were missed in the dark, or maybe she was a stoic child who didn't particularly discuss that she was starting to have symptoms. But clearly it is concerning, and it brings an important point that epinephrine is not the magic bullet if we wait too long. And that we need to know how to recognize anaphylaxis early. We don't need to get into the false illusion that we can take Benadryl and that would be enough to cover a severe reaction, and or at least be enough to head it off. Benadryl is not the appropriate therapy for anaphylaxis. So I'm very saddened by this story. I'm saddened too because everyone now is so alarmed that, well, maybe there's nothing we can do. And I don't want it to be a heightened fear. I want us to learn from it and know that we need to react, and we need to react in an intelligent way. and tried to intervene early enough. So, and as I stated in this particular case, she did go on to have vomiting, but it was at the same time that she was having severe respiratory distress. Usually FARE or allergic living oftentimes will come back a year or two later and discuss how patients died, and I suspect we'll get a little more information on this one on down the road. But it is concerning. So I'm going to do my standard. Here's my 12 slides. Everybody who knows anything about food allergy knows my 12 slides. But I do want to bring everybody up to kind of the same place so that we're all talking about food allergy in the same text. First of all, food can be any substance that we put into our mouth. That includes drinks or gums or preservatives. And food allergens are the proteins or the specific parts of those foods that we make an immune response to. I do want to be very clear again, when we're talking about food allergy, we're talking about immune-mediated adverse reactions that are specific and reproducible. There are lots of reactions that are food intolerances. And for example, my best example today is I can't eat donuts. Why can't I eat donuts? Because they make me burp all day long. I don't know why. I took all the school nurses' donuts today, and I was like, oh, I really want to eat a donut so badly, but I have an intolerance to donuts. I can't explain it. My mother has an intolerance to cucumbers. Probably some of you all have intolerances to watermelon. You can eat the food. It makes you uncomfortable, but it's not life-threatening. And I do want to say, for the purpose of the rest of this talk, when we're talking about food allergies, we really are talking about significant food reactions that can be potentially life-threatening or IgE-mediated. So, what we do know is that 2 children in every classroom currently in the United States actually has a diagnosis of food allergy. And that's pretty significant. And yes, we are seeing an increase in that. That involves 6 million children, or 1 in 13 school-age children. And as you all know, the statistics are that 90% of the causes of anaphylaxis are in fact food allergy, and that accounts for 30,000 ER visits per year, 10,000 hospitalizations, and very fortunately only 150 to 200 deaths. And the most common foods that cause those reactions are peanuts, tree nuts, and shellfish. These are the most common foods we see in childhood and adult, and you can see that most adults are not allergic to milk and eggs. Those are foods that are commonly outgrown. And you can see that sesame seed here has made the list now, is probably the 9th most common food that we're seeing reactions to, and that has to do with our changing diet in America. So why do we see the increase in food allergy? Most people think that it's probably some public health changes in our environment, certainly the way that we introduce foods into the diet may be a factor. Pregnancy may be a significant factor in terms of stress, in terms of Tylenol exposure, antibiotics exposure, reduced fiber in our diet, lack of good bacteria, multiple other factors. There may also be an increase in food allergy because we're doing too many tests, and some of these may be false tests. And there was a recent article in the New York Times that did reiterate that we're having a lot of false positives, people that are getting the wrong test from the wrong doctor and being told that they have multiple food allergies. And then there's a lot of discussion that we're waiting too long to introduce foods, and that probably in most children, the high allergenic foods really should be introduced within the first 12 months of life. And then I'm sure that there are plenty of other reasons that are yet to be elicited. GOKs, God only knows. Certainly not me yet, but we'll keep looking for it. So the natural history of food allergy, as you all know, is that most children become tolerant to soy, wheat, milk, and egg, and that peanuts, shellfish, and tree nuts, as well as fish, tend to be lifelong. Time to resolution can be as late as in the teens, and that the IgE level, or that serum blood test that families latch onto, doesn't necessarily show the degree of severity. We really use it more for positive and negative, but we do know the higher levels are associated with slower resolution of those allergies. And we do know that oral food challenges are the gold standard for determining when they have outgrown their food allergy. And just to throw up there, I get this question all the time: when do most people develop tolerance to their foods? You can see that 20% of peanut allergic patients develop a tolerance. You can see that, for example, wheat, even by age 12, only 65% have actually developed a tolerance to their wheat allergy, and those numbers are there for you to see. So let's talk a little bit about anaphylaxis. Anaphylaxis is a serious allergic reaction. Most of all of you all either know it personally or have family members that do, or you probably wouldn't be here at our support group, so I recognize I'm preaching to the choir, so I'll be very concise about this. It is a severe allergic reaction that's rapid in onset and can lead to death. The most common causes are food, medication, stinging insects, and sometimes latex allergy. The allergic manifestations that we look for involve 4 major organ systems. The skin can have itching, redness, hives, eczema. Cardiovascular, we can see, GI, we can see anything involving the nose or the eyes. We can also see nausea, vomiting, abdominal pain. We can also see respiratory issues that involve wheezing or cough. And then most kids, if they're having anaphylaxis initially, are tachycardic, and then as it progresses, they can develop hypotension. So, and these are classic pictures of skin reactions. These are hives. Hives you need to be able to feel in order to call them hives. Red blotches don't necessarily constitute hives, but may or may not present before the development of hives. And it's important to recognize those. But probably more importantly to recognize is that hives don't always happen in anaphylaxis. And oftentimes we get caught up on waiting for the hives before we decide to give the epinephrine, and that can result in a more severe reaction. Just to remind people what we do know about fatal anaphylaxis, we do know that respiratory symptoms are the predominant overwhelming component of fatal anaphylaxis, that skin symptoms, as I just mentioned, may not be present, and that oftentimes there's a biphasic reaction, which is why we always say whenever we use epinephrine, we do want to go onto the emergency room, and for most patients, we recommend that they stay at least 4 hours. The problem or the underlying issues that seem to come up more for fatal anaphylaxis do involve delayed epinephrine, and oftentimes adolescents are at higher risk, partly, as I like to say, because they become stupid and they stop listening to what their parents told them about reading labels or asking before they try a food, and they become too concerned with fitting in, being part of the norm. So, and again, we talked about also the key foods, and most of the anaphylactic events that result in death actually occur away from home, where people may not be as prepared as they should be for an allergic reaction. So in the school setting, which is what we want to focus on tonight, we know that food allergies do affect a lot of school-age children. We know that there's been an increase in food allergy in the survey period that we have been monitoring recently, and we know that about 15 to 20% of kids actually have experienced an allergic reaction to a food at school. We also know that 25% of cases of anaphylaxis occur in children who were previously undiagnosed, so some of these first reactions are in fact happening at school. And we know that preschool-age children experience food-induced anaphylaxis more commonly than older children, but very fortunate, if you remember the 10,000 hospitalizations, the 30,000 ER visits, and only 150 to 200 deaths, the majority of the allergic reactions that we're seeing in this country are not fatal and are managed with appropriate medication. So this is an important slide that I do want you to remember. Again, hives are only present in 88% of cases of anaphylaxis, not 100%, and it can be some other combination of those symptoms. So I want to spend about 2 minutes talking about where we got our current policy for our schools, and to do that I need to take you back to some stories of some remarkable children who, because of a very significant tragedy, did have a significantly positive impact on our schools. The first one is 9-year-old Nathan Walters, and in 2001 he died from peanut allergy in Spokane, Washington. He was a known peanut allergic child, and what they actually had done is gone on a field trip, and on that field trip they handed him the same bag lunch they gave every other child. And in his bag lunch was a peanut butter sandwich, a peanut butter cookie, and actually a trail mix that actually had peanuts in it. Now, he was a bright child, and he knew to give away his peanut sandwich, and he also gave away his trail mix. But he didn't give away his cookie because his mom had made a cookie that looked just like that for him, and he thought it was probably a safe cookie. When you read about the details of his death, what you find out that he initially had some GI discomfort, and he didn't feel well, and they actually left him on the bus with an adult while the rest of the kids went on the field trip. And he actually remained on the bus for almost 2 hours while the field trip took place before they decided that the reaction was progressing, before he had profound vomiting and respiratory distress, and subsequent to that, it was too late for the epinephrine. An important point here, though, is that because of his death, his community became very motivated to make sure this never happens again, and they developed some important community-wide education policies for the school that have become a gold standard that we have used nationally now to implement in our school systems to help keep kids safe, also on the field trips. The other person that I want to mention at this moment now is Sabrina Shannon. Probably those of you that know anything about food allergy know about her story. Sabrina died in 2003. Sabrina lived in Canada, and she was an 8th grader, and Mom was trying very hard to teach her responsibility and the ability to help protect herself for her food allergies and give her more independence. And so she had actually checked the week before on French fries that she felt were safe. She'd read the label. She'd talked to someone back in the cafeteria. They didn't fry it in anything that she was allergic to. The label seemed safe. She'd eaten one, seemed to do fine. So she actually had a discussion with her mom on the morning of her death. Please, 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 Mom, let me have them. I've checked it out. I know they're safe. I'll be careful, etc. But what she didn't know is that the utensil that was used to serve her French fries were cross-contaminated with the cheese fries that had been served to the other students. And she went on to have what she thought was an asthma attack. And she presented to the school office saying that she was having a difficult time breathing. It's my asthma, it's my asthma. And for whatever reason, there may have been some delay in giving epinephrine. She had a full arrest there in the school office. They were able to resuscitate her. However, there had been significant brain damage at that point. But from her very tragic death, Sabrina's Law came place in Canada, which is a beautiful work of, if that's true for anything in law, I guess. It is very helpful law that actually put in place policies and strategies for schools to be able to implement safe plans, to help reduce allergen exposure, to communicate with parents, to look for accidental exposures in the school setting, to put all the pieces in a puzzle that need to be in place in a school setting to keep a child safe. And they not only did that, but they required individual plans that help maintain individual policies for each child too, so that the children can be safe. And this law is still in effect in Canada and was very important. I want to mention to you another child, Caitlin Carlson, in 2010 in Chicago, was a 7th grader who at the end of the year semester, or end of Christmas semester, they decided to have a reward party for everyone doing well for that. semester, and they decided to order out food from a Chinese restaurant. And she did have a known peanut allergy, and in spite of the fact that multiple phone calls were made to the restaurant, and the restaurant assured them that they would be able to provide a peanut-free meal for her, it did not happen. And the meal was cross-contaminated with peanut protein, and she did have a life-threatening allergic reaction. The other thing that happened with her is, once again, her presenting symptom was respiratory distress. She didn't present with hives, and there was delay in giving epinephrine. There wasn't epinephrine available with her name on it initially at the school, and this delay in epinephrine appeared to be tragic. Because of that, though, Chicago developed policies, though, for stock epinephrine, that there would be epinephrine in their school systems that didn't have anybody's name on it, that would be available to treat a child in the event they would have a severe allergic reaction. And because of that policy, just simply 2 years later, here in Virginia, we also have stock epinephrine policies, as you know. Unfortunately, it came on the heels of another very tragic death. Maria is a little girl who was 7 years old right outside of Richmond, who inadvertently had a peanut somehow or another exposure on the playground. She did develop hives, but also developed shortness of breath. She was taken to the school office, where once again there was no epinephrine with her name on it, and there was delay in treating her anaphylaxis. From it, though, we now have a state law. In the state of Virginia, all public schools are required to have stock epinephrine available. And I can tell you, having now come full circle of 1 year with stock epinephrine, it's been used a lot. I don't know of any fatalities in any of the public school systems in our area this past year, and I feel very good about the school nurses feeling comfortable and having an ability to replace the stock epinephrine once they've used it now, and they have a greater comfort for recognizing when they do need to use it. And as you all know, if you are reading the FAIR website, there is a bill that's already passed Congress, asking for nationwide stock epinephrine to be available in schools, and I understand a similar bill has gone to the Senate. I checked about an hour before I came here, and I didn't see that it had passed in the Senate yet, but we're all very hopeful that that will pass, and then we'll all be very optimistic that financial resources will become available to provide stock epinephrine for every school. So, having said that, I do want to spend a minute about what we do know we can do besides have stock epinephrine available. We do know that the management and treatment of I have them in my pocket. So I apologize to anyone that may be watching. I have a cold, and I'm trying to manage it and talk at the same time. I will pause a moment and drink my life-refreshing Diet Coke. Good stuff. And we will resume discussing about management and treatment. Obviously, it's important anytime you have a food allergy, we want to do strict elimination. We want to learn key words. We want to watch for hidden allergens. We want to know a lot about the allergies, and we also want to have an emergency action plan. I do want to make a note here for people who are especially concerned about the schools. Unlike what probably most of us are taught, it doesn't look like most of the allergic anaphylactic reactions that happen are happening in the cafeteria. Actually, the larger majority of them are happening in the classroom, and that's partly because we are a food-centered nation where food is the reward and the end-all, be-all of everything, and we have a lot of food in our classrooms. Rarely are the reactions triggered outside or somewhere else in the school. There are some key medical facts that I want to review, and then we're going to talk about things you can do for your school. The first one is that food allergy is an immune response. It's predictable, and it affects multiple systems in the body. Even a small amount of food can cause the reaction, and there is no cure, knock on wood, at this moment for all food allergies. The way that we want to treat them is by prevention. An allergic reaction usually occurs within seconds to minutes after ingestion, but in a few rare cases can occur 2 to 4 hours later. The severity and the progression of the allergic reaction is unpredictable. We don't oftentimes know the threshold amount that will cause the reaction. We don't know what other foods may be present in the stomach that might delay absorption. We don't know if they have a fever, and that may increase absorption. There are multiple other factors that can come to play. So we need to treat each reaction as a significant reaction and observe closely. And then we want to use prompt epinephrine. That's very critical. And a second dose oftentimes is necessary. And as you all have seen this slide before, but it's such an effective slide, accidents are never planned. We need to be prepared. I oftentimes will tell my patients that your epinephrine, you should think of it like your safety belt. Every time we get into the car, we buckle ourselves or our children in. We do that not because we're expecting to get in an accident, although there are plenty of idiot drivers out there. We are mostly doing it to be safe in the unlikely event. And your epinephrine should function like your safety belt. You shouldn't go anywhere without it. You need to know that it's always present just in case. So, as we mentioned, anaphylaxis is a two-system reaction, and we talked about also that oftentimes there's two waves to the reaction. We call that a biphasic reaction. After everything can look good, the allergic response can happen all over again. Oftentimes it's within 1 to 4 hours, which is usually why we recommend that most individuals stay in the emergency room for about 4 hours. And something that we are stressing very much this year, and you'll also see it in a moment on our life-threatening allergy management plan, the treatment of choice for anaphylaxis is not Benadryl or albuterol, it's epinephrine. And we need to help encourage our school nurses and our teachers and bus drivers and coaches and all of those people to not be afraid of epinephrine, not be what I've had some parents tell me, well, we were told to wait until they were blue, and then we could give. I certainly hope that we would act on it much quicker than that. And that's a direct quote, that we were told to delay it until they were significantly respiratory distress. We want to give it early. So this is a checklist for parents of children that are going to school. I think it's important for parents to become informed and educated. They need to prepare and provide information about your child's food allergy and medication to the school. They need to build a team. They need to help ensure appropriate storage and administration of the epinephrine. They need to help to reduce food allergens in the classrooms. They need to think about what they're going to do for school meals. They need to address transportation issues. They need to be prepared for field trips and extracurricular activities. They need to think about bullying, and if it is in fact happening, they need to think about how to stop it, and they also need to think about prevention for bullying, and they need to think about transitioning their child as they mature to self-management. And several of these concepts are available on the FAIR website, and if any of you all need to have any of these checklists, I'll be happy to provide them for you after the talk. So, first of all, you need to be well-versed on your child's food allergy. As a parent of a child with food allergy, it's critical that you know exactly what foods that they must avoid. You need to know what the signs and symptoms of an allergic reaction are. You need to know the ways that your child might describe that allergic reaction. Oftentimes, in the younger kids, they're going to talk about maybe their tongue is itching or the roof of their mouth feels funny. I have one child who always tells me that she has a spicy mouth, and that's her way of understanding that something's not right inside her mouth. Try to learn the words that your child may use for food allergy. And then you need to know, again, that epinephrine is very important and at what point you would need to give epinephrine. And then you also need to know how to correctly use your auto-injectable device. There are now 3 auto-injectable epinephrine devices that are currently available on the market. Most individuals feel that they are one no better than another. There are strengths for each of the devices. And whatever device your child has been prescribed, you need to make sure that you're comfortable with it, that you know what its limitations are, you need to know how to keep it safely, and you need to know how to use it. And that's something that should be reviewed with your medical provider. We also know that there is sometimes substitution. Sometimes the pharmacy, based on whatever your health care plan is, thinks that they are interchangeable. And what we are, at least nationally, trying to do as an allergic organization is trying to say, whatever you got, at least give them what we taught them so that they do know how to use whichever device they're given. And so we're trying to advocate for not substituting devices based on whatever the insurance plan is, or make sure that you've learned all 3 devices so that whichever one your insurance decides to fill, that you're appropriately trained for it. We think that you should probably, if you have a child who has life-threatening allergy, have seen a board-certified allergist so that you can get adequate education and also get good resources. And there are websites that are available that can tell you which are board-certified allergists in your particular communities. You also need to know something about your school. How do they generally manage kids with food allergies? Then that may mean making a few trips in there, find out some other parents who might have kids with food allergies there, and find out what they say they've learned or what they've had to implement in order to feel like their kids are safe there. And third, you need to learn as much as possible about your school's approach to food allergy management, and then develop a school team, which we're going to talk about. And then you need to remember that one shoe doesn't fit everybody's foot, and that there are some families that have higher anxiety levels or more significant food allergies than other families, and that there may be some children who need to be, based on age or whatever reason, at a allergy-free table, and there may be other children who don't need to, and you need to help individualize the care plan for your child. So let's talk a moment about preparing and providing information about your child's food allergies and medications. So this is the new school form that's been developed. It's called the Life-Threatening Allergy Management Plan, and it's new, and all 8 of the Hampton Roads public school systems, with the exception of Norfolk, have adopted this particular plan. And what I'd like to do is just go over it with you just a moment, because you're going to be seeing this given to your child from the allergy care providers or from your school nurses. And all of the school nurses that I have taught in the school systems that I mentioned, and also I did the in-service for Virginia Beach public school nurses back in, believe, February, are all using this form. So in this particular form, things that I'd like to point out are, first of all, here we do have a box where individuals that are extremely reactive to a certain food, that will be put in that particular box, and with any exposure whatsoever, you don't wait for any allergic symptoms, that's an automatic move on to epinephrine. Most families won't require that box to be filled out, but we do have some children who've had such severe reactions over and over again that we know that we have just a matter of minutes sometimes before we need to give epinephrine. So, or if we have someone that perhaps maybe has a stinging insect allergy, that box may be filled out. If they get stung, we're not going to wait to find out whether it was a wasp or a bee. We're just going to go ahead and give epinephrine. So the lineup here is going to name what allergies the physician thinks they're allergic to, and then we divide up into minor and major reactions. For the minor reactions, basically what we're saying, if there's an itchy mouth or a few hives, then we're going to go ahead and give an antihistamine. What you'll notice this year is that not only is Benadryl listed there, but so is cetirizine or Zyrtec. There's been a recent meta-analysis that has looked at the onset of action between cetirizine and Benadryl, both in the liquid forms, and they're very comparable. The reason for adding cetirizine is that there are some children who get profoundly sleepy with Benadryl, and it's very hard to know if their anaphylaxis is progressing because they're so very drowsy. And so Zyrtec may be a good option for some of those children. But what we have seen in our practice is probably 98% of them are still having Benadryl written as the antihistamine. So the dose of the antihistamine would be here. And the advice then that we are giving to the school is that the nurse should stay with the student, they should alert the parent, and then they should observe to make sure that nothing additional happens. If the child presents with 2 things happening at once or single severe symptom, then we're going ahead and giving epinephrine. So 2 symptoms would be, for example, swelling of the lips and vomiting, or a single severe symptom would be, let's say the child comes into the school nurse profoundly hoarse, and they weren't hoarse 20 minutes ago. I don't need you to wait for hives. To me, that's a significant single symptom, and I think that warrants epinephrine. What's different from last year to this year is that you'll see we are not giving Benadryl, we're not giving albuterol, we're giving epinephrine. If they present with 2 symptoms or a single severe symptom, they're automatically going to epinephrine. And you'll see here that the EpiPen's listed, the AviQ, and a blank for any other additional epinephrine that might be required. We're immediately calling 911. And then one of the things that we're stressing this year too is that you need to give the epinephrine time to work, and we don't want to have a significant positional change in the child. So if the child is more comfortable when you give the epinephrine and they're sitting, then go ahead and leave them sitting. Don't suddenly stand them up and run them off to the nurse's office or, out the door to get in the car or whatever. We would recommend that you give at least about 5 minutes to get the epinephrine to have time to work and for them to become stable in terms of their blood pressure and the amount of blood in their heart. If they're laying down, leave them laying down. And if you have a choice between sitting and laying down and it's not too much to lay them down, then probably laying down would be optimal before you give the epinephrine. And if the only thing you can do is because they're standing, I guess you could give it standing, but we don't want to have giant positional changes initially. And then after you have given the epinephrine, we want you to notice what time you give the epinephrine. And then we want you to consider repeating the dose as soon as 5 minutes or later than that if for some reason things are not getting better or the anaphylaxis is progressing. And then what the school nurses are telling me they are especially happy about is this one right here: transport via EMS to the emergency department. I can tell you at least 3 or 4 stories of school nurses that have told me that they've given epinephrine in their schools and the kid looks good, and then the ambulance comes and the EMTs say, well, why'd you give epinephrine? They look good. Do we really need to transport them? And the school nurses have felt very much at odds with the EMTs and have felt like that they shouldn't be second-guessed, that the EMTs weren't there at the time the epinephrine was given. So this is a standing physician order now, and there's no room for discussion. They're going to the hospital. We also have had at least a couple of incidences where the parents got there before the ambulance did, and the parents have said, oh, they look fine, I'll take them home and watch them. And that certainly has made the nurses uncomfortable too. So this current order in the school systems are if they get epinephrine, they get transported. And then on the form is provided additional contact information. So what our goal here is to make it very clear and concise and not to dance around whether or not we need to give a lot of ancillary medications. We want to emphasize, again, if you think they're having anaphylaxis, we need to give epinephrine. Is that pretty clear for most people? Yes?
My daughter has ectopic atrial tachycardia, so her heartbeats are already fast. Is there... And the cardiologist obviously said, well, give it to her because between breathing and heart, you can breathe.
It's still the therapy of choice. And that's still the way that we'd go if we thought they were having anaphylaxis. And I personally, too, have talked with a cardiologist in our program, and I say, they have this particular heart defect or this particular arrhythmia. What do I do if they're anaphylaxing? And they said, give epinephrine. So you may discuss... I don't know that necessarily it might be an option depending upon what her cardiac pattern is, whether or not they'll use a reduced dose, but I've not seen that done yet in my 23 years.
Give it to her and deal with it later.
Yeah. Right, well, because you got to have a beating heart in order to, yes, so... good question, but as it stands now, everyone gets epinephrine. So there is another form that's available, and some of you all may have used this form. This is the new FAIR form, and it came out about 6 weeks ago. And it has information on the first page that, again, delineates mild symptoms and also has more severe symptoms. And as you can see, it also targets you more towards injecting epinephrine immediately if you have severe symptoms, and if you have some mild symptoms, if there's an antihistamine ordered, you can give that. And then this page I like a whole lot here, which actually has pictures of all 3 devices that are available and how to use those devices. And I anticipate probably as the Hampton Roads Life-Threatening Allergy Management Plan group comes together again this year, we may very well adopt a second page that looks very similar to that. They are accepting in the school systems this FAIR form also because it has such national standards, although their preference, at least as a group I understand, is that they know the other form better and they prefer to have standardized forms, but they will accept this form. And there's a third form that's also available nationally that they will accept, and this one is from the American Academy of Allergy, Asthma, and Immunology, and this can also be obtained, I believe, on the FAIR website and also at the Quad AI website. And basically what it has, again, is a view of what things are involved in anaphylaxis, and then medication options, both with antihistamines and auto-injectable epinephrine. And all three of these forms are available. So as we talk about auto-injectable epinephrine, is there anyone who's not seen the new AVQ at all? So let me spend just a moment to mention that. In the last 12 months, we've had a new auto-injectable epinephrine come out, and it's called AVQ, which stands for Audio Visual Cue. That's why it's called AVQ. I thought at first it was AVQ, like French, but it's not. So basically what it is it's a very small pocket-size epinephrine. It's in a hard turtle shell. I'm told from the pharmaceutical representative that they actually ran over it with a car, and the turtle shell survived. Not that I would be throwing my EpiPen out around on a car, but and seeing if you're able to run over it. But the thing about it that is so unique is that it actually talks like an AED does. And so if you are someone who's very anxious about giving epinephrine, or you've never given epinephrine before, both the trainer and the real device actually talk you through having to administer the epinephrine. So I'm going to show you that real quick.
This trainer contains no needle or drug. If you are ready to use, pull off red safety guard. To inject, place black end against outer thigh, then press firmly and hold in place for 5 seconds.
Now, I don't think I can get my knee up that high.
To inject,
so I will do that over here.
Against outer thigh, then press firmly and hold in place for 5 seconds. 5, 4, 3, 2, 1. Injection complete.
So what you would do, just like in the EpiPen,
Trainer may be
you would inject it on the outer thigh, and you can also go through clothing. And just to point out to you, if you are helping to administer it to someone who might be particularly obese, the closer down to the knee that you go, you're more likely to get intermuscular instead of interfat. So that's usually the recommendation that we make if you have a particularly muscular or large child or a large adult. Yes?
Make much of a difference whether it's the side of the thigh or the front of the thigh?
Not really. Most individuals go along the side part of it, but it could be on top of the leg, and that would be fine too. And it goes through clothing just like the EpiPen. A couple of points to make about both devices. First of all, neither one of them should get frozen, and neither one of them should be left out in extreme of heats. I tell most of my patients that if it's more than about 80 degrees outside, then that neither one of them probably should be left in the car, because an 80-degree day outside is about 120 degrees inside your car, and that's probably too high, and the medicine may break down. There was a death that I want to mention back in March, a young man who was home from college. I can't remember his name off the top of my head, but supposedly he accidentally ingested peanut with a known peanut allergy, and they scrambled around in his house to try and find auto-injectable epinephrine, and when they found his EpiPen, it was expired. And my understanding is, from listening to the mom's interviews on TV, is that she was advised by the 911 operator not to give the epinephrine because it was expired. And so I want to encourage you to always have an updated EpiPen, but if the only thing you have is an expired EpiPen, it's better than no epinephrine. But optimal, obviously, is having auto-injectable epinephrine that is not expired. And then the other thing to know about this particular device, which hint, hint, if AviQ people are watching this, they need to do laundry studies with it. They need to put it through the washing machine and tell me what happens if you leave it in the pocket, which they haven't done yet. And to me, that would have been a lot more logical than running over with a car, because real life situation, my kids have tons of stuff in their pockets that I miss when I do their laundry because I'm not awake. But anyway, those have not been studied. And the EpiPen is not, it's a little bit bigger and bulkier and sort of falls out. So I don't know that the laundry issues would be such an issue. But this is very exciting for certainly families that may be overwhelmed with even the thought of having to give epinephrine. This device may help them greatly for that. And obviously for individuals who have no medical background at all, and they may be needed to step in a minute's notice, much like the AEDs, this particular device may help them do that. So, and then the other thing that it is it's competition. Whenever there's competition, prices come down. And that means it's more affordable for most individuals. And currently, at least the two major manufacturers have great zero copay coupons because one had it, the other one had to get it. So I'm finding these are much more affordable, which is obviously very important when we're trying to provide them for our families and patients. So, and I don't know what you're going to do yet with the lithium cell battery when it's all over and done. Most people, they bring me their expired EpiPens, and I use them whenever I'm trying to do teaching. I don't know what the correct manner is going to be, if there's going to be, you know, at Harris Teeter, a bucket for you to dispose of your expired AviQs yet. It hasn't been around long enough for anybody to know how we're going to get rid of the lithium batteries yet. And I do know on the trainer that I think it's 362 times that you can demonstrate the trainer before it no longer talks, because I've gone through 2 or 3 of them now. So anyway, your children will be excited to do it, and don't be surprised if a couple months after you've gotten it that it no longer talks, because I guess it only talks for so long. But the new ones, the real ones that are not the trainers, they'll always talk because you won't have used them before. So, and they only have single dose in them, and they are prescribing dual doses. Because you should always have 2 doses of epinephrine. So we need to have avoidance. We need to have action plans available. We need to build a team. And by team building, I think what the best thing to do is before the first day of school, try to meet the members of the team, to introduce yourself and to share information about your child, to find out what the people on the team already know about food allergies. Oftentimes your teacher will say, well, last year I had a peanut allergic child who did X, Y, and Z. Is this what we need to do for your child? You do want to provide information on the basics. You want to clear up any misconceptions that the teacher or the school nurse might have, and you want to discuss the role of each team player, especially if you're in a school that doesn't have a school nurse. You want to make sure that who's going to call 911, who's going to be there to help stay with the child, who's going to administer epinephrine, who's going to go meet the ambulance, who's going to calm the rest of the class. All of those roles need to be thought about as you are potentially preparing for an allergic reaction at your child's school. You want to make sure that you provide the action plan. And while I'm thrilled we have stock epinephrine in our schools, it does not take the place of you providing an action plan and auto-injectable epinephrine with your child's name on it for the school. Leave the stock pens if we can for those kids who need a second dose maybe, or a third dose, or kids who are having their first time reaction. And I feel very frustrated that because we have stock epinephrine, some parents have become very cavalier about providing that dose of epinephrine. And so I'd like to encourage you all, if you haven't done so, to do that. I think that's very important. You want to involve the school community. We want to be clear and consistent. We want to educate the peers in age-appropriate manners. This may mean going in and on story time to the kindergartners, reading one of the old fan books about Leo the elephant who can't eat peanuts, or watching Blinky Goes Peanuts, the Arthur series when he develops peanut allergies, or providing some other story that does review for younger kids. Or in the older kids, I think it's important for your child to be able to talk about their food allergies with their peers, but not every single person in the entire world needs to know every single detail about it. And they need to discuss it in an appropriate manner so that they're not alienated or isolated. And those things come age appropriately, and we can talk about those in just a little bit. But we do want to make sure that all the adults who are involved in the child's care throughout the day are properly educated. And what that means is including the school nurse, which needs to get the medicine and the action plan. And if you haven't done so, I would go meet with your school nurse and make sure that they are comfortable with what's on the plan and they understand who to contact and how to get in touch with you if there were an allergic reaction. I think it's important for them to also meet with the student at whatever appropriate developmental stage they are, review for them that they're not supposed to share and take other people's foods, that they need to make sure that they've cleared any foods that they would eat with either the teacher or the school nurse to make sure that they're safe. And you need to obviously talk through the lunchroom situations. The school nurse then is responsible for trickling down the information to all the other people that come in contact with the child. They're responsible for training the staff and reviewing the child's day to make sure that all the people along the way are educated. The teacher is very important, and oftentimes I encourage people to go meet their teacher and make sure that their teacher understands what an allergic reaction would look like and that they would never hesitate to give epinephrine if they needed to, or that they are aware of what needs to be done to create a safe classroom. And then you also need to find out what they're going to do for substitute teachers and how often. How many times last year did you have a substitute teacher? Or are you going out on maternity leave? These are all issues that need to be thought about at the beginning of the school year. And then make sure that you've gone in and trained the teacher on how to use auto-injectable epinephrine. And then one of the most important things that happens at least once a year, never, ever, ever send the child who has an allergy alone to the school nurse. Somebody needs to go with them because the allergic reaction could progress as they're en route. And I can tell you some wonderful stories where children's lives have been saved. I can think of one child I know of in the local area where her friend, as she said, I feel funny, I'm not doing right. I'm going to the bathroom, and her friends yelled to another girl and said, go get the school nurse, and she stayed with her in the bathroom and helped alert finding her more quickly and getting epinephrine to her. And that was a very bright middle schooler who knew not to leave the allergic child alone. And so we want to make sure that our teachers know that too. Sometimes we need a letter home that will kind of help the other families that may have the child. We send in so much food, and sometimes it's important to let the other parents know that there may be a peanut allergic or milk allergic child in that classroom, and sometimes that helps people adjust to parties, or sometimes it's easier just to be the class mom if you have an allergic child, and then you are in better control of what foods come into the classroom. Portsmouth Public Schools last year had put forth a policy that there was going to be no food in the classroom. They were very excited, and they got shot down. So currently I don't know any school systems in the public school arena in this area that have a no food in the classroom district-wide policy. But we'll keep pushing for that. And then just a point here, you do want to remind the teacher that bullying can happen with food allergies. I'm sure they've had 14 in-service videos on bullying, but they may not always think about it in the context of food allergies. And I know of a child right off the top of my head in one of our school districts in the second grade this year where another little boy thought he was teasing her and kept taunting her with his peanut butter sandwich on multiple occasions, and then actually did in fact rub peanut butter on her. She did have an allergic reaction that did require epinephrine. She did fine, and the school appropriately disciplined the child and expelled him for 3 days. Even though he was a second grader, he certainly understood a little more about bullying, and was an opportunity for them to teach the other kids at the school about the aspects of bullying. So don't forget the coaches. Don't forget the field trip personnel. And one important point I want to say here is that we need to be smart with our teenagers because oftentimes they feel isolated, and 94% of them in one particular survey said that that was the worst part about having food allergy. So we need to give them independence, but we also need to make them feel like they're part of the group. And those are that you've heard Rebecca come and talk to us. As you recall, Rebecca does everything. She's actually just graduated and now off to college, but there wasn't anything that Rebecca missed out on, and she made good decisions, and her parents felt strongly enough that they had educated her appropriately to be able to manage anaphylaxis and ask the right questions that, certainly even traveling without her parents was not something they ever thought twice about. So we want to help ensure appropriate storage and administration of the epinephrine. Where do we keep it? We prefer it not be locked up. Each of the different school systems in the area have different policies, but we also want to be able to self-carry it when it's appropriate. And oftentimes, remember, the school nurse leaves at 3 or 4 o'clock, and in those kids that go on to play sports, the epinephrine needs to be available in the school bag or the sports bag for after-school activities, or if they're in robotics club, they need to have epinephrine available. So those are things that we need to think about also. And we need to make sure they're not outdated doses of epinephrine and that they are stored appropriately. We want to help reduce food allergies in the classroom. Again, not only is it the actual food that comes in, but sometimes there are multiple contamination. We know that there could be food allergens in soaps and lotions. We know that there can be contamination under the surfaces of tables, and little kids who unfortunately touch everything around them and everybody and every chair and every knob and every button. And we also know that sometimes even crafts can have particular food allergens. Yes?
I was just going to ask if you could address at some point we may be planning to cleaning the surfaces.
Yeah, well, I'm going to talk about cleaning of surfaces in just a bit. So, and we want to make sure that we also think about cross-contamination. And I don't know that we're any safer with nut-free rooms or nut-free schools. Certainly kids who don't have a nut allergy, they have milk or wheat anaphylaxis too, and we don't create those particular environments for them. So, and sometimes people are lulled into a false sense of security that maybe we're a nut-free school, but then so-and-so brings something in their lunch that nobody policed. So I think we need to be appropriate at any time for any food. And again, ideally, if we could move all food out of the classroom, we'd be better off. We want to encourage hand washing, and this is the moment where I will remind you that Purell gives you germ-free hands, but not allergen-free hands, and that it takes mechanical washing of the hands in order to remove the allergen. And the same thing is true for surfaces. So we don't want to use the same sponge or the same cloth where foods that are allergic for a child have been eaten, drag around that peanut protein, and then go over and wash the allergy-free table with the same cloth. Usually what I recommend is spray and wiping, and that's usually the optimal way to clean surfaces. But when we clean surfaces, we need to clean under the tables too, and the chairs, especially if they're young kids, all the places that they would have in fact touched. So if you think back when you used to chew gum in school, and remember how you'd stick your gum anywhere and like, oh, there's a crack in the table, I'm going to stick my gum right there. If you think about all the places you could put gum, then you can think about all the places you could put food allergens, and all those places need to be cleaned too. Of course, now no one ever chews gum in school, but back in the day, we did chew gum and stick it everywhere. Yes?
The commercial wipes that you mentioned, are they just like the wet wipes or the antibacterial wipes? Or?
I don't need them to be antibacterial. I think any wipe is fine. Baby wipes are fine as long as you do several wipes. And I think 3 or 4 wipes are probably adequate, but not one wipe. And I don't care whether or not it's, 99.9%. I'm really germ-free. I'm really just trying to mechanically get the area clean. So baby wipes are fine if that's what you've got. You just have to use several. And the other things that you need to think about are school meals. You need to think about transportation issues. You need to be prepared for field trips. We talked about bullying, and then we want to be able to assist our child as they move towards self-management. Meals could be probably a whole lecture in and of themselves, but we do need to make sure that cafeteria identify foods properly, that they are trained on allergy issues such as cross-contamination in preparation and serving of the meals. We need to make sure that labels don't change frequently. Sometimes it's good to post pictures of the kids with food allergies actually in the classroom. I don't mean in the classroom, in the cafeteria, in a place where not everybody can walk up and say, oh, Ben, he has a peanut allergy, but maybe behind a door where the cafeteria personnel can be alerted and watching for those individuals. Sometimes we need seating arrangements that minimize exposure. Food allergy kids shouldn't have to sit alone, though. And there are lots of different ways we can do the strategies that other kids can eat with them. We do want to encourage good hand washing with soap and water. And again, we want to wash surfaces. Transportation, ideally, we'd have a no food policy on our buses, but just because that policy exists doesn't mean that it ever happens. There are times when you might need a special seating arrangement. Certainly in our individuals that are carrying their auto-injectable epinephrine in their backpack, I think it's very reasonable to make some kind of a tag that can go on an outside zipper, that epinephrine can always be in that pocket, and they can show the bus driver, look, my epi's right here if I ever need it, or to their best friend that they sit with, my epinephrine's always here if I ever need it. And then if the school systems will allow the bus driver to be properly trained, and that's a whole other can of worms that we'll touch at some point. So, and then we ultimately need to transition our children to be young adults and be able to carry their epinephrine with them at all times. They need to realize that prompt administration of epinephrine is important. They need to know, additionally, if they're not able to carry it, they need to know who has access to their medicine and how can they get to it quickly. They need to raise awareness among their peers. They need to avoid eating ingredients that are unknown. They need to not share. They need to wash their hands before they eat. They need to read labels. They need to know how to recognize symptoms. I have some 7- and 8-year-olds that they get that feeling and they're dead on it. They're right. They're having a reaction. And just simply based on how they feel, they can tell you. And you need to tell the people who provide care for them, listen to my child. They know. And they're right. And so we need to give epi when they say they need it. Sometimes we need medical identification jewelry, especially in the really young kids that have multiple care providers. And again, we need to appropriately address bullying. I like this poster. If I could buy a couple thousand of them, I'd put them throughout the schools. They're actually in Canada, and it basically says, you would put this up in a cafeteria or somewhere that says, can you save a life? Think fast. These are the symptoms. You give epi and call 911. These are great resources that probably all of you all already know. The FAIR Food Allergy Research and Education website at foodallergy.com, our FASGOT website at FASGOT.com. Is it foodallergy.com or foodallergy.org? I just screwed that up, didn't I? All right, let me change that slide. I'm sorry. It should be foodallergy.org. After I said it, I was like, that's wrong, isn't it? Don't go to that website. Go to foodallergy.org. Also, the Quad AI and the college have good resources, too. And there are some published papers that have looked at different school settings. This is our new FASGOT webpage. If you haven't been there, it's all smiley, happy colors, lots of good information. Go visit our website. And then I always like to end my talk with a picture of my lovely children who keep me sane most days. I have been very fortunate. My oldest boy did, in fact, outgrow his peanut allergy. But for those of you that wonder why I'm so passionate about food allergy, I got a little help by having had a food allergic child, too. 2 of the 3 are asthmatics. One of them is severe dog allergy, and the other one just is goofy. And that's a real question. Which one's goofy, right? And that's, for the most part, all I want to say tonight. However, I'd like to thank the audience at home that's viewing for tuning in, and I'd like to invite you to come to our next FASGOT meeting, either by web or actual meetings, which are also posted on our website. Thank you for the presentation. We'll now end it there, and I'll come answer questions.